Talk about new to dialysis versus veterans to dialysis.
Okay.
New dialysis patients don't tolerate well because it is a shift of fluid rapidly, both out of the body and back into the body.
Okay.
So that physiologically, meaning how your body normally works, that can affect you. So they won't tolerate that because they're new to it. I find that the persons who are optimistic, hopeful, and still live a good quality of life, they have good support. And also in the units, the dialysis patients, they can become like a family.
Okay.
So if you also have good patient-to-patient support, that's good. Life is really what you make it. Yes, it's end-stage renal disease, but you still have a long life that you can live once you put your mind to it. Take charge of your life. You are able to fare very well. There are good stories out there. You can have a child while you're on dialysis. I have a testimony for that. So don't think of it as a death sentence. Just take charge of your life because it's only one life you have to live.
In Office with Dr. Jevon Samuels.
Welcome to another episode of In Office. I am Dr. Jevon Samuels. In Office is a program which we normally talk about life, sickness, and death. And today in office with me is a young, brilliant medical doctor. Her name is Dr. Kimone Young. Welcome to the show.
Thank you. Thank you for having me.
Okay, sure. All right, so today we'll be talking about kidney disease in general and also renal kidney replacement therapy, right? So with no further ado, let's get into the show, right? All right, welcome again.
Thank
Dr.
you.
All right, now, kidney, I've known you, admire your hard work with the kidney patients over the years, right? And I really see that you have the passion for the kidney, right? So when I invite you on this program, we definitely have to talk about the kidneys, all right? So this is a program for the general public, so I just wanted to tell the general public, what are the kidneys and what do they do?
Okay, so your kidneys are what I like to call your garbage bins of the body. Let's put it that way.
Okay.
It gets rid of all the toxic waste that your body will create. But apart from that, it also is in control of balancing out your body. So it helps to ensure that certain molecules or electrolytes in your body are normal, so they'll help to correct abnormalities as well. And it also plays a role actually in making sure that your blood count is remaining normal. So yes, they're the garbage bins of the body, but they also serve many factors, which really boil down to what we call homeostasis, which is maintaining normal body function.
Okay, all right, well said. Now, what are the different types of kidney disease that we have?
Okay, so there are many kidney disease that exist. The most common one is chronic kidney disease, which is disease that you get after you've had prolonged period of kidney damage, at least whether it is because of the structure, meaning there's something physically wrong with the kidneys, or functionally, which is you have abnormal function of the kidneys. So we look at the blood test for that, and you have it for about 3 months or more. So you can have chronic kidney disease, but you also have other things like genetic things. You can have weird and wonderful things, names we're not going to really get into. And you can also have what we call acute kidney injury, meaning just because you're sick at the time and your kidneys are not necessarily getting all the things that it needs, you can have short-term damage to the kidneys. But it should be noted that that short-term damage can lead to long-term damage. So in a nutshell, that's the kind of kidney disease that you have: acute, chronic, genetic, weird and wonderful, and maybe structural. Like that's also another thing, like something wrong with the kidneys, like you're born without one, or you have two, or you have a lot of cysts in them. So those are the kind of kidney problems you have.
All right, you're basically intimate with the field, with the kidney patients and disease. All right, I was reading an article recently which said that there's a gradual incline in the incidence of chronic kidney disease and the need for renal replacement therapy. Is there a study that was done as in to ascertain the major risk factors that have been occurring in recent years? I think there was a trend from between the 1980s to about 2000. It's basically almost, the graph seems like the exponential increase in the number of kidney cases. In terms of the research that's going on, what are some of the factors that they think is causing this trend? rapid
Okay.
increase.
Alright, no problem. So some of the factors really have to do with that there has been a rise in non-communicable diseases or lifestyle diseases, which is like your hypertension, your diabetes. And I think the rise in chronic kidney disease is because you have more risk factors, for example, smoking use, alcohol use, and then as well as our diet. If we're going to be very honest with ourselves, our diet is not what it used to be back in the day.
Okay.
So the decline in healthy diet has also led to worsening hypertension and diabetes, which now leads to increase in chronic kidney disease.
Okay.
There's also a rise now because I do believe we've become a little bit more sensitive to the existence of chronic kidney disease, so we're picking them up a lot more. So that's also happening. So before, a person may have been overlooked or underlooked, or everybody would have been classified maybe as acute.
Okay.
Now that we're doing more screening or more conscious because of more health education and promotion, we're picking up the chronic kidney disease much more. So based on the studies, risk factors, lifestyle, hypertension, diabetes, smoking, alcohol, and then your diet. Those are the reasons why we've been seeing this gradual incline and increase, and it's also because we're actually screening and picking them up a little bit more than before.
Okay. Alright, so you mentioned the word screening and as in one of the factors why we are picking them up a little bit earlier. But what exactly do you do in screening? What do you use to screen for kidney disease?
So to screen for kidney disease, we always do what we call your urea and electrolytes. It's a blood test that is done. And when you go to your private doctor, if you do the executive profile, it will come up. So that's what we would do. We would screen using your urea and electrolytes. Another screening modality or another screening tool that we use is that we ask you to pee in a cup, and we put a stick in the urine, and then we look at what is on that dipstick. We call it a dipstick. And based on what it shows up, you can let us know if you have any damage to the kidneys or not.
Some of the symptoms these persons normally present with say for example the person missed the screening process. What are some of the symptoms that persons normally present with a doctor, which the doctor should hit to have a high index of suspicion for kidney disease?
Okay, so your symptoms are based on excess urea or excess toxins in the body. And how does that present? Your body is trying to get rid of them. So nausea, vomiting, loss of appetite, you don't feel like eating. Some patients will also lose weight. Some patients will get headaches. What can also happen is that you'll have electrolyte abnormalities, meaning your potassium might be too high or too low, or other electrolytes like calcium. So you might have what we call twitching or jerky movements of the body. Also confusion is one, and the very bad case, seizure activity, so a whole body shaking. Some persons can come in a coma as well. There's also skin changes. You can also have like on your legs or your arms, the skin can either get extra dry or extra itchy as well.
Okay.
And you can also see like a change in your color. If you are presenting very late, there's also a complication where you can get like bony pain or bony abnormalities. So like you realize that your fingers changing a bit, or you're just having a lot of muscle aches and muscle pains. So a high index of suspicion, anybody who's constantly vomiting, can't eat food, and they may have like generalized weakness, or they feel weak and tired all the time. Another thing that can happen is that because you have chronic kidney disease, you can have reduced blood count, so you look like you're anemic.
Okay.
So you can also come in with like shortness of breath, you're blowing short, or your heart is beating very fast on your chest, or you feel extra tired.
Okay.
What can also happen apart from that, came out of my brain, I can't remember right now, but yeah, so shortness of breath. Fluid overload. So for the patients who the kidneys stop working because they also filter out water, what can happen is that they will have excess fluid being stored in the body in places not supposed to. So for example, your legs will swell up, your belly will swell up, or even water fluid will be in your chest. So you realize that you're either blowing short again, or you're coughing because you have fluid in the chest. Or even the eyes will get puffy as well.
Okay. Alright, so if a patient is then diagnosed with chronic kidney disease, alright? What are some of the additional blood tests that we would do in terms of to elicit like other causes apart from the hypertension and diabetes?
Okay, so the workup for chronic kidney disease, once we do the screening, so we do the dipstick, we do the the blood test to check the kidney function. We look at your blood count because a complication is anemia, so we look at the blood count. There are some blood abnormalities that can lead to kidney disease, so doing the blood count is also important for that. There's some infections like hepatitis B, hepatitis C, back in the day COVID, C13, which is HIV, syphilis, so we'll also do those as well. But there are some primary kidney diseases. Those are a little weird and wonderful. Don't worry about the name. So for example, vasculitis, which is C-ANCA, P-ANCA. We can do anti-GBM. Don't worry about the names. Anti-GBM, we can do your ASTO as well, because we're looking for post-streptococcal glomerulonephritis. We can also look at things like your IgA and your IgG. You can also look at your C3, don't worry about the names. These are all autoimmune related primary diseases of the kidney that you can do. So we'll work you up with those blood tests. We'll also check your liver function. We also check your cholesterol as well, and even in some cases your thyroid function. Apart from that, for workup, we'll also do renal tract ultrasound, which is your KUB. So we look at the kidneys, we've got the tubes coming from the kidneys, and we look at the bladder, right? So your kidney, ureter, and bladder ultrasound, because even in some cases for like men, their prostate can lead to kidney disease. So in the blood test, we'll also do your prostate screening test for them. So we'll do all those blood tests, we'll do the ultrasound, and we'll do the dipstick. And if you have protein, we'll do something called a 24-hour protein. Yes, you get a bottle and you collect all the urine in that bottle, and then we'll measure how much protein is coming out for 24 hours. All
right, well said. Now, so a patient is diagnosed and they're worked up for kidney disease, right? But I know it's the chronic kidney disease at different stages, and it's normally a gradual progression until you reach end stage. But there are some of the things that guys normally tell the patients in order to get them ready for dialysis or other forms of renal replacement therapy.
Okay, this is a heavy question, but remind me to break it down. So the first part is, yes, there are stages. There are 5. Stage 1, 2, 3A and 3B, 4 and 5. By the time a patient is at stage 3A, 3B, we begin to start. Now the stage 3A, 3B is when the doctor will tell you where you are. But at that point, you might hear things like, you are at risk for going on to renal replacement therapy. What is renal replacement therapy? 3 arms. There is the renal transplant, there's hemodialysis, and there's peritoneal dialysis. Transplant is a new kidney in your body. Hemodialysis is a catheter in your chest, and you go on a machine and we pull the blood. Peritoneal is that we put the catheter in your stomach, and we use your body, the peritoneal fluid, a little fluid, to pull off all of the solids or pull off all of the toxic waste that are there. So that's the stages of chronic kidney disease and the types of renal replacement therapy. You are correct to say that it is a gradual progression, and there are factors that influence worsening progression. Some of those factors include acute kidney, so anything that will cause you to get like an infection or not controlling the underlying reason for your chronic kidney disease. So let's say it was pressure. If you don't control the pressure, it will progress quickly. If it was sugar, if you don't control the sugar, it will progress quickly. But let's say you get a sinus infection or a really bad chest infection or a really bad urine infection, you might have been stage 1 or stage 2 when we saw you, but after that infection, if you didn't recover well, you can be at stage 4.
Rapid progression
because of infection. Right, so that's one of the things that can happen. Now by 3A, 3B, as I said, is when we start to have conversations. What will that conversation look like? We'll start to let you understand that the benefit of dialysis is probably better for you at this stage. So we'll talk about the access that you need, whether that is a fistula or a catheter. We'll talk to you about the options, as I explained what options of renal replacement therapy there are, and then we'll also talk to you about your diet, right? And exercise is still something we've been talking about before, but your diet does change when you get closer to renal replacement therapy regions. So you'll hear us talk about, are you a candidate for getting hemodialysis, which is the blood dialysis, or are you a candidate for peritoneal dialysis? That's the first discussion. Peritoneal dialysis, we We suggest it for all of our patients. Why? It has many advantages, and the biggest advantage I found is that they give the patients autonomy. You are in control of your dialysis. You get to do it at your home, and it is also inexpensive compared to hemodialysis, where it's ideally you need 3 sessions for the week, but we do 2 here, and it allots more time. You don't have as much autonomy. Also, hemodialysis can give you more complications with your heart compared to peritoneal dialysis. Renal transplant is an option, but that does take time because you have to find a suitable donor and you have to be worked up to see if you qualify for renal transplant, and that can also be expensive. So we'll have the conversations about what are your options. Then after you've decided your option, we'll have the conversation about what type of access. So if it's peritoneal, getting the peritoneal catheter and scheduling your surgery versus getting a fistula, which is a surgery that is done to join 2 of the blood vessels in your body, an artery and a vein, to create high pressures to put you on the machine. But that also takes some time. So we have to do that from early. Or we're going to talk about, do you need a catheter, which is a tube inside your body to be able to pull those large amounts of fluid. So that's the conversations we start to have in terms of types of renal replacement therapy, the access that you need. Then the diet portion is that you now have to be careful of what you consume and in how much quantities. We will give you a dietitian referral and you can speak specifically to the specialist, but there will be changes to, for example, how much calories you take in, how much protein you take in, how much sodium you take in, and how much phosphorus or phosphate that you will take. And then there might be some drastic adjustments to your medication as well, because studies have shown where there are medications in recent times that are known to slow down your risk of progression. I want to reassure anybody watching this, you can have chronic kidney disease at stage 3 or 3B and you don't go to end stage. You can stay there for a very long time once you are properly managed and you do what you need to do. So it's not a must that you have to go to end stage. It's only if you don't do what is required. But every case is, individualized.
All right. Something
I
that
hope I answered the question.
Yeah, it did comprehensively. All right. You made mention that some advantages of peritoneal dialysis over hemodialysis, that you have the autonomy, it's less expensive. So what are some of the factors that where we have like so many hemodialysis patients compared to peritoneal dialysis? What are some of those factors that you use to screen them, why we still having more hemodialysis patients than peritoneal dialysis? Alright,
so a good tidbit to understand is that most chronic end-stage renal disease patients, I think internationally diabetes is the leading cause, which in Jamaica is hypertension. One of the relative contraindications, especially in Jamaica, to peritoneal dialysis is that when we started our PD program, we saw that a lot of diabetics, they didn't heal well after getting their peritoneal dialysis. So that kind of excludes you already from getting PD, and that's a large amount of our population anyway. So that's one of the reasons why we won't navigate to PD for those patients. Apart from that, we have an issue with late referral. So it is where, yes, we're picking them up a little earlier, but by the time they really need dialysis, they're so far gone, their clinical is very unwell and need a quick access. So we'll end up going into hemodialysis first to save the life or to reduce the symptomatology. Because understand that peritoneal dialysis is a surgery. You have to be on a bed and you have to make sure that you're fit for surgery. Compared to hemodialysis, where it's a little quicker, we can do that very quickly. For the patients. So as a result of that, we will later referrals, we'll jump into hemodialysis first. And then, even though we might see somebody as a candidate for peritoneal, we offer it, they get so accustomed to hemodialysis. And even though peritoneal gives you autonomy and you get to do it on your own, some persons are okay with just tell me the 2 days I have to get dialysis and finish, compared to every day when they have to write and look and follow their own charts. So the care system has made adjustments to much more hemodialysis than peritoneal dialysis, which is why persons will opt to just stay with hemodialysis and why you'll see more hemodialysis. Another thing is also resources. We don't always have the resources needed to put in the catheters, and it also takes some time because of peritoneal dialysis. We have to go to your home, we have to inspect to see if you have running water, can you read and write, can you follow, and there's also training a part of it. So the setup for peritoneal dialysis takes much more care and much more insight compared to the setup for hemodialysis, which is why you will see more hemodialysis than peritoneal. But we are lobbying to get more peritoneal dialysis now.
Alright, so renal replacement therapy, hemodialysis. So like a typical, how does the machine work in terms of the patient is on the machine, they have to take the blood from the patient. How does that process work?
Okay, so that process works by whatever your access is, fistula or catheter. The machine uses pressure to pull the blood from you, and it runs it through what we call, big word, don't worry about it, extracorporeal circulation. It's just some lines that they run the blood through, and then you have a membrane that is created or built synthetic. You run the blood through that membrane, and then through the principles of diffusion, meaning moving from high concentration to low concentration, they filter out the toxins, and they will take excess water with it as well. And then pretty much that's how you clean the blood, and then we return that blood through those very same lines into your body. So that's how it works. Other parts of the machine, we can give you things to help with the dialysis session. We'll also give you a little blood thinner to make sure it doesn't clot, but we'll just take the blood from you, run it through a membrane, clean up the blood, and send it back.
Alright, so the aspect of in terms of the function of the kidney, which function of the kidney the machine takes over? I made mention of a certain function that the kidney has earlier. So which function the kidney takes over?
So the machine takes over removal of the toxins. And so it really does that, as well as removal of water. So the kidneys help to, when you urinate, it's water. So the kidney, the urine contains those toxins, really. So the machine does that, takes out the toxins and takes out the water, excess water in your body.
And so what are the other stuff that we would use to help with the other functions of the kidney, such as the hormone for the blood and bone and calcium? I think it was calcium.
Calcium, right. So complications of end-stage renal disease, one is anemia. So after every dialysis session, you will get what we call a EPO, which is something to stimulate the blood count. So, or to stimulate production of red blood cells to build up the blood count, because the kidneys have this very same hormone inside to create it on its own. But if the kidney stops working, it can't do it on its own. So we give a molecule in your body to help to stimulate the blood cells to be created. So that's one. Another thing is bone mineral disease, and that's when you have increased phosphorus and decreased calcium and you feel a bony pain. So what we can do on the machine as well is that we can afterwards we give you something to help with the bones. So it's an IV injection that we can give. Then if your calcium is too low, we can give you calcium on the machine, or we can even adjust some of the parameters of the machine, because the machine has something what we call acid and base. So we can adjust the acid to make sure that your calcium goes up. We can also give you like a high sodium bath on the machine for the other electrolytes, and then we can determine how much fluid to take off. But realistically, it's dependent on your weight. That's how we do it. Like how much weight did you come in, and how much, based on a calculation, we'll determine how much fluid we can remove from you.
Alright, based on my limited observation with a few renal patients, like some persons will tolerate their full session while others struggle to tolerate like an hour to 2 hours on the machine. What are some of the factors that from patient to patient, some persons tolerate the hemodialysis while some don't?
Okay, that's true. But let's talk about new to dialysis versus veterans to dialysis. New dialysis patients don't tolerate well because it is a shift of fluid rapidly, both out of the body and back into the body. So that physiologically, meaning how your body normally works, that can affect you. So they won't tolerate that because they're new to it. And one of the things that can happen is where you get like this this almost like this blockout picture because of how much fluid that we're taking off of the patient. So that's new. That's why they won't tolerate this, because they're new. For those who are veterans now, it will be like the complications associated with dialysis itself. So remember that hypertension and diabetes have complications like heart problems or low blood pressure. So it'll be those other complications that would make them not tolerate.
Okay.
So you can have persons who like lose weight. So because they're losing weight, the weight that they come in is different. So the amount of fluid that you're pulling off each time is different, and your body reacts to that. We can have patients who they have developed low blood pressure and they still have fluid, but because the pressure is low, we can't pull off the fluid, so they won't tolerate that. We have patients who they have still uncontrolled blood pressures because they're not necessarily getting the dialysis as adequately as they should. So you'll be on the machine and your pressures are still above 180, so they won't tolerate those 3 hours. We can have patients who their calcium is very low, for example, so they won't tolerate the full time, or they will cramp. They will cramp a lot, and because they're cramping a lot, they can't tolerate the full session. I think those are some of the reasons as to why some patients won't tolerate a full hour. Most of the time, I really recognize is you need to ensure that you have good doctor follow-up. So a nephrologist needs to be looking and assessing your prescription all the time, because that will determine how your sessions go. It shouldn't be that you've been doing like a month or 2 months and a doctor hasn't reviewed your prescription to see what has happened, versus you just starting and then you know being a veteran in it. So I think that also contributes as to why persons won't tolerate their sessions, because there hasn't been a review of their prescription to determine the adequacy of dialysis as yet.
Yes. All right. Another, like a general thing I noticed with persons on hemodialysis is that like some persons basically actively working and living happy on the machine, and then have another set of patients that seems like it's like something about they like it's such a heavy psychological burden that they can't function. They basically give up on life. So what are some of the team members involved, or it's probably potential additional chronic or comorbidities that they have, why have such a significant variation in persons on the machine?
Okay, I feel like that is really based on family support. I find that the persons who are optimistic, hopeful, and still live a good quality of life, they have good support. And also in the units, the dialysis patients, they can become like a family. So if you also have good patient-to-patient support, that's good. For those who don't really fare well, I find that one, they're younger, meaning they haven't really lived life just yet. So the younger ones don't fare well, and that's when you don't have support around you. So team members, from a medical standpoint, we will ask the social worker to get involved at times, and there are some nurses and doctors and physiotherapists who they may become a little bit, attached, or they will try and help where they can. I can anecdotally say that I've helped people make sure they get jobs, or give them encouragement to say that it's not a death sentence. And I'll share a story that I love to share.
So go ahead.
There's a patient in my unit who she's been on dialysis for like 15 years, and in the year of 2022 we realized that her belly was getting a little bigger. We're just like, that's weird, because she's pulling off a regular fluid, and then we did a pregnancy test and she was pregnant. And we were all a little concerned, because we're just like, boy, we don't want you to necessarily be pregnant and would not follow you up, but we were able to see that baby all the way through the end. When that baby was born, Samuel, I went over NICU and looked for that baby. And this baby is now 2, and we call her Miracle, because it is a miracle to be on dialysis for 15 years, then get pregnant and have a successful pregnancy, meaning she didn't have any problems or complications. All we did was just dialyze her 3 times a week and just watch her weight. And then when the baby was born, baby had no abnormalities. So that to me is just a testament to life is really what you make it. Yes, it's end-stage renal disease, but you still have a long life that you can live once you put your mind to it. and that's just a female. From a male perspective, he was on dialysis for 20 years, and he told me that when he started, the other men said to him, boy, you know, say after a while it won't work, you know. But he was able to give birth not to one, but to two.
Okay.
So you can still live a long, successful life. I know teachers, I know people who are financiers, and they're still able to show up for their jobs.
Okay.
You just have to understand what your prescription is it adequate, and to speak very often to your doctor. So the disparity between those who do really well and those who don't do well, support, mindset. Those are the two things. And support and a mindset come from both a healthcare perspective as well as a family or interpersonal perspective.
Okay. All right. So normally, in terms of the literature base, how long persons normally live on hemodialysis? Like they can, what's the
I would
record?
say 30 years.
30
to 40
years on hemodialysis. Okay, good.
Right now, the longest one I've had in my experience, it has been 25 to 26 years.
25, 26, okay.
Because there have been young ones that they started when they're like 16 or 17, 35, 38, and they're still fine.
Okay, so with current hemodialysis procedure and technology, you should be able to basically live out a normal life expectancy. So it's not really a death sentence.
It is not.
Alright, let's talk quickly before we wrap up, talk a little bit about the peritoneal dialysis, because most of us, including even some doctors, are not really fully familiar with the patients because they normally go at home. So what's this process like, and how does it work? What does the patient have to do? How they manage, etc.?
So peritoneal dialysis is where we put the catheter inside the belly and we use the membrane in the belly. So remember before I had said that on the machine is a synthetic membrane. This one is your natural body. We have a setup, so it's like a stand, and you get bags of fluid, and then the bags of fluid run into your body, then it stays there, and that's how it pulls it out slowly, or we call it like a gentle continuous dialysis, we call it. So it pulls it out, and then after some time has passed, you drain it out. So we have the run-in, which can be 20 minutes or less. We have the dwell time, which is like 3 to 3.5 hours, which is similar to hemodialysis. That patient is 3.5 to 4 hours. So you dwell for that time, and then you run out, and you're supposed to run out all the way, but for the most part that will take about half an hour. So that is the setup, and that's after we've placed the tube in your body. For the patient, what you have to do is to put up that fluid using sterile procedure. So your gloves, you wash your hands, you unwrap your catheter itself, and you attach it to the setup, right? And then after you've done all that, you have to document. You have a chart. I should have carried my chart. You have a chart where it's almost like I wouldn't say a graph, but like tables, like a table with lines, and you put in what time you run it in, what time you start, what time you stop, what type of fluid you placed in, how much fluid went in, and then when you're running it out, what time you started to run out or to drain, and what time that stopped, and how much you drained out. And then you have to do the calculation to subtract. If you put in 2,000, which is the average time, and you put out 2,500, how much did you gain or lose? For this time you would have lost 500, so you'd write 500. But let's say you put in 2,000, but when you drained out you got 1,500, you'd have gained 500. And then based on your prescription, which might be 4 cycles for the day or 5, you then have to add up to see how much did you lose versus gain. And then we also empower them to take their own vitals. So you need a blood pressure machine and a thermometer. So we tell them to do their blood pressure and we write on the chart. So that's what the patient have to do. But importantly, you need to have a room by yourself to do it in. You have to make sure that it's clean, and you wash your hands, and you have clean running water. So that's what the patient would have to do for themselves.
Alright, now in terms of kidney transplant, I know, do we do them in Jamaica?
We do. This is a little bit out of my scope, but the knowledge I do have is that we do have a kidney transplant clinic at hospitals. I do know that there was a foreign company that came in, I think in Montego Bay. They had offered to do that, but transplant does occur. I know before my time, they used to do a lot more, and there was a patient that I was managing at my unit who had a kidney transplant. But for now, we do write the referral, we do encourage them to go to transplant clinic. So it does happen. How how quick or ready or the expenses around it, I don't have that much knowledge to share.
Okay. All right. So just give us just some general complications of hemodialysis and peritoneal dialysis, and then we can wrap up. All right.
Okay. General complications. After hemodialysis or during?
No, like potential complications that they can have developed, like infected catheter, I guess, or some other stuff that you should
Okay. So related to the dialysis itself and not kidney disease.
Yes.
So yes, you can have catheter-related infections, and that will require for you to like be admitted. So that's like you're on the machine. If it's hemodialysis, you're on the machine and you get fever, chills, so you're shivering or you're vomiting or just pain. For peritoneal, they can get catheter infection as well. That's when you have fever, abdominal pain, and vomiting. So you can have catheter infections. You can also have just your catheter just not working.
Yes.
So we call it malfunctioning. Sometimes it's just clots that blocks up the catheter, or it can be what I've seen happen is like a catheter has been in so long, like a permanent catheter, and it actually adheres to the body after a while. So you can have malfunctioning catheters, or like for example, because it's a tube, so you'll have like some of the catheters having a kink or a crack. For those who are fistula, you can have your fistula clotting. So your fistula can block off or it stop functioning, like you're not getting flow through the fistula in your arm. Some other complications of dialysis. So sometimes it can go like unresponsive, or like you lose a little consciousness because like let's say your sugar drops a little or your pressure drops a little. But for the most part, and you can also get chest infections a lot. That's because you're getting dialysis in a healthcare facility and you interact with other people who may also be sick, so you can get chest infections as well, especially if it's just flu season. But I believe those are some of the most common complications of dialysis.
All right, so well said. All right, so Dr. Young, just give one summary on chronic kidney disease and renal replacement therapy, and then we'll call it a good session, all right?
Okay. Chronic kidney disease is as a result of your lifestyle. It's as a result of poorly managed, most times, hypertension or diabetes. It is something that if we go to your doctor early, we can catch it and we can slow your progression to needing dialysis. But when you do need dialysis, options are there, and you just need to figure out which option works best for you. Don't wait before it's too late. It is something that if you take charge of your life, you are able to fare very well. There are good stories out there. You can have a child while you're on dialysis. I have a testimony for that. So don't think of it as a death sentence. Just take charge of your life, because it's only one life you have to live.
Okay, all right, well said.
Thank you.
Okay, thank you very much for taking time out of a busy schedule to come and have this discussion so others can benefit, all right?
Well, thank you for having me, because I do care about the kidneys.
Okay, all right, viewers, remember to share, like, subscribe to this channel to help the growing community. So I want you guys to contribute to the basically medical information, and remember that a disclaimer, you should always seek medical attention. So this channel is for information based and not necessarily for diagnosing anyone or treating. All right. Is there anything else you'd like to share with the public?
Yes. So you can find me on Instagram at KYMMA_1. I do offer private care to patients. I can come to your home, or you can come and see me at the office. But if you go to that Instagram page, you'll find out information, or you can email me at drkyung106@gmail.com, and that's where you can find me. Also, let's let the public know that just like Dr. Samuels is doing, I have a passion for health education as well as just sharing more my platform. Yes. So I've actually entered a competition called Mrs. Universe Jamaica. No, I am not married, but the competition does have an arm where you can be single. And I believe that utilizing this platform is good for me to be able to, just like this, share information with the general public to let them understand that your life is yours and the quality of life that you want is in your hands. So you can also go to official Mrs. Universe Jamaica. Coronation night is July 5 at AC Hotel at 6 p.m. So you can visit that Instagram page, and you can purchase the tickets to come and support me. Thank you. I appreciate that. I would have worn the sash if I would have worn it if I knew.
All right.
Yeah.
All right.
Thank you.
Be Be sure to subscribe for more informative contents on life, sickness, and death.